So we had a young lady who walked in. She didn't walk in. She was in a wheelchair with extreme back pain. And she had a breast cancer which had spread to all her bones and was compressing her spine, so she couldn't move much. Dr. Sanjay was the radiotherapy. 10 doses relieved her of the pain, relieved the pressure on the spinal cord, started moving a little bit. Once she was a little fit, Dr. Joy removed off her ovaries because her tumor was dependent on hormones. Then both of us gave her hormonal therapy and targeted therapy, and she came to the clinic day before looking like an absolutely normal person, walking around, conducting her life. And I think she lives in Jharkhand and she's really leading a normal life now.
The most futuristic thing in oncology today.
No, I think I told you about it. I think flash radiotherapy, nothing can beat that.
What's more critical, dose accuracy or timing precision?
I think it's dose accuracy which matters most.
Biggest challenge in cancer care today.
Making the patient see the treatment through.
Journey, what's the most critical point where care should be focused?
Recovery, whether it's from chemo, radiation, or surgery.
Hello and welcome to Sahyadri Health Talks, a very special edition. Why special? Because I have the entire team of oncology from Sahyadri Hospital Hadapsar. Without further ado, let me introduce you to the panel. So we have with us Dr. Shona Nan ma'am, Director of Oncology, Sahyadri Hospital. Dr. Srinivas sir from the Department of Medical Oncology. Dr. Sanjay sir from the Department of Radiation Oncology.
Hello.
And last but not the least, Dr. Jay Ghosh sir from the Department of Surgical Oncology. So, to Srinivas sir, genetic testing, how it helps in determining the treatment when it comes to oncology?
Right. So genetics as a cause of cancer comes into the picture in almost 15 to 20% of the patients. Rest of the patients, they have their cancer developed sporadically. Now this genetic testing comes in different ways, and what are its clinical implications is that both therapeutic as well as preventive. So suppose, say for example, if a patient is there and patient is having history of breast cancer and there are a couple of more relatives that have been affected by breast cancer or ovarian cancer, we do test genetics in that particular patient, which are often called as index cases.
Achha.
And if some genetic abnormality comes, we treat them with medications which actually acts against that particular genetic abnormality. Now there is one sibling, the sister of the patient, that comes and asks me the same question. Now how should I prevent myself getting a cancer in a similar way? So if person's genetic test comes positive for any abnormality, we do test other siblings, mother or other blood relatives, first degree relatives actually. And if any specific genetic abnormality comes positive in them, they have its preventive applications. So before any cancer is developed, we can keep these patients on close surveillance by regular following them up for clinical examination, doing certain radiological investigations or blood tests as to find out the tumor markers, and we can get hold of the disease, at its earliest outset. Or there is something called as, I'll involve Dr. Joy also into the picture. There is something called as, preventive surgeries. That is also coming up in a big way.
Absolutely.
And we
Preventive
have
surgeries.
preventive surgeries. So if a patient has, some genetic abnormality, but the patient is absolutely asymptomatic, and I would like to, call upon Dr. Joy in between, because
And we have several such families
Right.
of young women with breast cancer in the family, ovarian cancer in the family. We have other patients who are young who have what we call a P53 mutation, where they are prone to almost any tumor coming anywhere in the body. So, and we have dealt with all these patients together. So, Joy, would you like to talk about prophylactic surgeries?
It became very well known after Angelina Jolie underwent a double mastectomy for this, because her mother was diagnosed with one of the cancer syndromes. The gene was the BRCA gene, in which the mutation gives you a very, very high risk of developing breast and ovarian cancer. So here you have the unique opportunity that you now know that you have a very high potential of getting cancer in the future. Today you have not got anything, no disease, nothing. But maybe 10 years down the line you will be having a breast cancer or an ovarian cancer. And you have the ability to prevent it. You can stop the cancer from occurring in the first place. And that is where the role of preventive surgery comes in. But again, that surgery is a fairly major surgery for the patient. The person is not a patient really. And that surgery also has its own implications, its own morbidity attached to it. So it has to be discussed in a lot of detail, and very strong motivation has to be there to perform such kind of a surgery in a patient who is otherwise not having any
Absolutely
illness,
normal.
otherwise completely normal. But for the future, you are doing this surgery to prevent a cancer which can be life-threatening. And this is where these mastectomies, a preventive mastectomy, a preventive removal of the ovaries, preventive removal of the uterus, all these surgeries are there in place. And we have the guidelines as well, which tell us that who is the candidate who can or should undergo this kind of a surgery. So that is there in place, and it has to be discussed with the families involved. And obviously when they're dealing with cancer already in one of the members of the family, it's not a very easy discussion, but yes, it's there, and it has to be taken up with the family members of the patient whenever such a thing is diagnosed.
And you'd be surprised, Indian women, when they when you talk to them, and some of them do opt for these drastic surgeries, especially if they're young and they've seen their loved ones or their sisters suffering from breast cancer. They are highly motivated to opt for these surgeries.
And it's not a small number. 15-20% is
Yeah.
1 out of 6. So it's not a small number.
Yeah.
So, ma'am, as a director of oncology, right? So, what goals do you have in mind when it comes to this beautiful team that you have in terms of innovation, accessibility, and a holistic approach towards cancer care for Hadapsar unit?
So we have implemented a few things, I would say, in the last 6 years that we've been working together now, and we've set up multidisciplinary tumor boards, molecular tumor boards. We have allied services. Our pathology is second to none. Our radiology and PET is excellent. We have a reasonably good breast center, in the sense our breast diagnosis is pretty up there, and we're able to pick up very, very complicated issues and deal with complicated cases. That, I would say, is the USP, because we're very perseverant, we talk a lot, and we can easily navigate now through tough cases. Apart from that, we have a softer side to oncology, which is very important. So we do have a lot of supportive care. We have an in-house psycho-oncologist who comes in every afternoon to talk to our patients during the clinic, or those who are taking the chemo in the daycare. Our daycare staff are absolutely superb. Daycare doctors are very good. We have a good dietitian who comes along. We have a physical therapy expert who visits us once a week. So we have all these other services as well. The plan is to keep improving the service, perhaps head more into precision oncology and set up dedicated OPDs for that, and run some of our own research. Another addition we've had to Hadapsar is that we've set up a DNB teaching program. So we have 2 students with us who are currently studying to be medical oncologists. Dr. Sanjay has got several people aboard doing fellowships in advanced radiotherapy with him. And we hope to develop more and more teaching and our own type of research, which we are looking at. So yeah, that's the direction.
Okay. So before I move into the next section of this podcast, one last question to ma'am. Walk us through a typical tumor discussion that you have when a case comes.
So right now we meet on a Friday afternoon and we look and we discuss very, very cases that are tough, that we are stuck with, so to speak. Ideally, every tumor that is diagnosed in the hospital should be run through a tumor board. But we are so busy practicing that we don't have the time. But since our clinics are very close to each other, we go to each other's rooms almost every day and discuss a case that, we want an input on. So the typical tumor board is all of us assemble, people from surgery, medicine, radiation, part of cancer, pathologists, radiologists, nuclear specialists, the juniors, and the case is put up, the history is read out, the images are seen together, so we can discuss them, get
Discuss it,
inputs.
yes.
The pathologist gives us his or her input on the pathology specimen. If operated or any additional tests, we discuss the gene testing if it needs to be done. And we try and figure out the way forward for that patient. We then document it, write our suggestions down, sign off on it, and we put it in the patient's
So
file.
it's a completely, complete board that discusses
Yes,
on
correct,
cases.
correct.
And the unique part about having this kind of a tumor board discussion is, if the patient today goes to the OPD, they'll come across only clinicians.
Correct.
That is a medical oncologist, a radiation oncologist, a surgeon, somebody who is practicing medicine in the OPD. He or she is never going to see the face of somebody who is diagnosing, a pathologist, the person who's doing radiology and reporting the scans, who's reporting the PET scans. They are never going to come in the picture in the treatment of the patient. Whereas this tumor board brings the non-clinical staff or the doctors also into the picture in the treatment of the patient, which never happens anywhere else. And those inputs can be fantastically additional,
Useful.
and useful, that the kind of information we get while discussing the actual clinical parameters with non-clinical staff or doctors is very, very important, and that gives us completely different dimension to looking at the patient. I think that's a unique part of a tumor board which doesn't happen in a regular
Many
OPD.
of the places, correct. So moving on to the next section, which is the rapid fire questions. So I'll start with Srinivas sir. Just a few questions. So very quickly, targeted therapy or immunotherapy? What's more exciting right now?
Immunotherapy.
Okay. Most misunderstood aspect of medical oncology.
Side effects of chemotherapy.
Okay. Biggest myth about chemotherapy you would like to bust? Faster
Not
sir,
really.
rapid fire hai. Okay, again, biggest myth about chemotherapy that you would like to bust?
So basically, not all chemotherapies are harmful.
Okay. One side effect patient worry about that's actually manageable.
Chemotherapy induced nausea, vomiting, and hair fall.
Okay. Caffeine during chemo, yes or no?
Yes.
Okay. Moving on to surgical oncology. To Joyce sir. Most common misconception patients have about cancer surgery?
That cancer surgery is, recovery is very difficult, and that's not so anymore. We can guide them through a very nice recovery now.
A surgical myth you would love to bust?
I don't.
None? Okay.
Oh my God.
Your personal ritual before scrubbing in?
So it's like going for an exam. Each time you do a revision, you revise the entire case, you look at all the necessary images, you look at the CT scan, the mammography, whichever needs to be done. You discuss with your colleague who's going to be operating with you regarding the steps of surgery, and you make a plan, because cancer surgeries can be long, they can be 6, 8, 10 hours. So you need to have a plan in place as to how you're going to approach this surgery. You need to talk to the anesthetist, how they are going to approach this surgery, and how the patient is going to be perfectly fine at the end of the surgery. So that's the plan.
So if you could eliminate one post-op complication forever, what that would be?
So in a lot of surgeries, when we, as you said, organ removal, we once we remove the organ, we have to join it back as well. So that's called the anastomosis.
Okay.
So when you join back the anastomosis, however well you do it, worldwide, the chance of it leaking is 10%.
Achha.
So if you could eliminate that 10%, then that would be fantastic.
One cancer type where early surgery makes all the difference?
I would say in oral cancer, definitely, because that reduces the morbidity of the cancer immensely.
Coming to Sanjay sir, radiation oncology. The most futuristic thing about radiation oncology today?
No, I think I told you about it. I think flash radiotherapy, nothing can beat that.
What do most patients fear about radiation therapy that they should not?
See, they feel saying it's like giving a current, giving a shock. It's like radiation means electrifying the body, you are under shock or whatsoever. I mean, that's
A radiation myth that just won't go away. You're tired of hearing it.
Oh, I'll tell you, a lot of patients have told he got radiation and become radioactive. I'm emitting radiation everywhere.
I have personally heard that. I have kids at home. I'm taking radiation therapy. I'm emitting radiations. So I've heard that. Yeah. So moving on to the next one. The oddest question a patient has ever asked you about radiation.
See, they say, oddest question I see, you've taken radiation, can we eat in the same plate? Can we go use the same washroom? See, they basically get confused with nuclear medicine PET CT scans. I mean, even they are isolated for an hour or two, but not forever.
Not forever.
So radiation, it's like the moment you're out of the radiation room, there's no radiation in you at all.
What's more critical, dose accuracy or timing precision?
I think it's dose accuracy which matters most.
Coming to our favorite Shona ma'am.
Don't do a rapid
Yes,
fire
yes,
with
yes. One
me,
rapid
please.
fire with you, please. Biggest challenge in cancer care today?
Making the patient see the treatment through.
One technology you wish would be available to every oncology center worldwide.
Precision oncology.
Your leadership style in one word.
Inclusive.
What's more critical for cancer center? Innovation or accessibility?
Accessibility.
What's one thing every cancer center should invest in but often doesn't?
Palliative care.
What's your one piece of advice for aspiring oncology leaders?
Just love what you do and keep doing it.
When you look at a patient's entire journey, what's the most critical point where care should be focused?
Recovery, whether it's from chemo, radiation, or surgery.
That's with the rapid fire, and I just want to wind up this podcast with one last question, which I'll ask ma'am. So, ma'am, doing this team approach, share one case with us which was very close to this entire team and how the patient has recovered wonderfully just because this team was there and it was a multidisciplinary team approach.
Very
One
difficult to
case.
give just one case. There have been
Okay.
so many that
Okay,
we have
just
treated.
maybe a mention of a few.
Can you
one.
remember? There have been so many patients. Come on, think. Joy?
So a very dynamic and entertaining 70-year-old patient who was 70 at the time he came to us.
Acha.
He had a rectal cancer. We just spoke about it, that how it is a debilitating surgery because it may involve a permanent colostomy. So he did not want that. He took radiation because as a treatment given to rectal cancer first, it shrinks the tumor very nicely. He became completely fine
I think it
because
was a
all his symptoms.
complete response.
Yes, he had a good response. So all his symptoms went away. Obviously, he had problems in passing stools, he had pain. Everything disappeared after the radiation. So he thought, I'm fine. I'm not going to undergo this surgery because it's going to remove the rectum. And he went on to Ayurvedic therapy. 1 year he carried on Ayurvedic therapy, thinking that he's absolutely okay. As expected, all the symptoms came back in 1 year. All the problems that he had. And he came in a very bad state. It explained to him that this is recurring. As in, there's nothing, it's not gone away. It's there still. The cancer is still there. But, I mean, his good luck that it had not spread anywhere else. The scan was clear. So we gave him some dose of radiation again to reduce the tumor and make it operable. We operated him, but thankfully the tumor had enough distance that we could we could preserve the last part of the rectum and not give him a permanent bag, which is something that completely he wanted to avoid. And he underwent the surgery well. He recovered very well. He was already 71 by the end of the surgery. He recovered very nicely. Went on to receive the chemotherapy as well, which is required after the surgery. After this surgery, and today he's 74. He is a entrepreneur.
Wow.
He is driving around on a scooter or a bike.
Okay.
He travels 100 kilometers a day. And he is living
That even I can't do.
and he is living a full life. I mean, I'm glad to say this, but I mean, and of course touch wood, but he's doing well, and that's something I think if you ask us as a team we brought about, that definitely as a team it
As
could
a
be done.
survivor who recovered, who got treated again, now who is doing fantastic.
And
So,
an elderly patient like that, but kudos to him that he's really maintained himself very well, his health, and he looked after himself. So that helps us help him.
So we had a young lady who walked in. She didn't walk in. She was in a wheelchair with extreme back pain. And she had a breast cancer which had spread to all her bones and was compressing her spine, so she couldn't move much. So the first thing Dr. Sanjay did was the radiotherapy. 10 doses relieved her of the pain, relieved the pressure on the spinal cord, started moving a little bit. Once she was a little fit, Dr. Joy removed off her ovaries because her tumor was dependent on hormones. Then both of us gave her hormonal therapy and targeted therapy, and she came to the clinic day before looking like an absolutely normal person, walking around, conducting her life. And I think she lives in Jharkhand and she's really leading a normal life.
I mean, yeah, she came, you got her to meet me, but I was like, who's this? Because she looks completely different from what
So
we saw
again,
her,
you know, the whole team
whole
worked
team.
with
what
the
we saw
patient.
her some time back.
So kudos to this team and kudos to the great work that all of you are doing. And honestly, the word cancer is such spine chilling word, but then it's all because of great path breaking work which you are doing. We still have hopes and we look forward to the treatments. So thank you so much to each one of you
Thank
for
you.
joining me in
Thank
this
you
panel
so much.
today.
Thank you
so much.
It was a very informative and beautiful session, and I just don't feel like ending this, but I'll have to now. So looking forward to having again all
Yes,
of
we
you
will.
on this.
We will.
Till then, thank you so much.
Thank
Thank
you
you so
much.
Thank you.